Florence.
So you're Andrew Liteplo, and you are really known into the point of care ultrasound world. So would you like to describe yourself a little bit for us and tell us maybe what are your passions in life?
In in life, sure, of course. Well, thank you for having me. This is very exciting. I am the division chief of the Division of Ultrasound, Emergency Ultrasound here at Massachusetts General Hospital in Boston. Um, and I do a lot of ultrasound. I teach a lot of ultrasound. We publish when we can. And my career, what I'm passionate about in my career is just spreading the word of point of care ultrasound, because as we all know, if you can do point of care ultrasound, you are a better clinician in many ways. What I like to do in life, I like to travel. I like to cook. I like music. I like um, connecting with people, and just kind of enjoying everything that life has to offer.
Wonderful. And I know you enjoy to travel thanks to the fact that you come almost every year to teach here in Belgium in our level 2 ultrasound course as well. And I thank you for that. How did you really get involved into the POCUS world? Um, were you mastered by someone, or did you take a fellowship because you were passionate about it?
Um, yeah, that's interesting. So during residency, point of care ultrasound was not something, it was just being introduced to emergency medicine residency curricula as a requirement. And so when I was a resident, we didn't have a very structured ultrasound rotation, but somehow I realized that it had a lot of potential and thought that it would be really interesting to do as a career. I was also very interested in global health, so I considered also a global health fellowship. But what I realized was that having ultrasound training could make me a much more powerful global health person to begin with. And it was much more versatile. And I tell anybody who's interested in ultrasound career that ultrasound can be whatever you want it to be. You want to be an expert educator, ultrasound can do that. You want to do global health, ultrasound can do that. You want to do research, you want to run a fellowship, you want to do admin, you want to run finances, you want to do simulation, you want to travel, anything you want to do, ultrasound can get you there and can make you better at it. And so I think it's doing a fellowship for me was probably the greatest career decision that I made, because it really just opened up a world of possibilities.
And do you really have one person that helped you getting there that you could name today?
Well, I think the ultrasound person most influential in my career was Vicky, of course, Vicky Noble, who you know when I came to Boston, she was already here as the ultrasound director, and I saw the opportunity to work with her as a great opportunity. Um, and for I don't know, many years, maybe almost a decade, the two of us worked together, and we were the ultrasound division, and we built the division. We started the fellowship. We um, revamped the residency curriculum, and we traveled a bunch, and we had a lot of fun doing it. Vicky, Vicky, but she's just a wonderful and warm and selfless, team-centered person, who's just very funny and charismatic, and and of course very bright, and she's a visionary. So the two of us working together was just wonderful, and I've always been lucky to have an amazing team with me here at MGH, and she was of course a large part of that.
Great. And so you said that you built a curriculum with her, and I know that you guys in the US managed to have almost all your emergency physician trained in POCUS. How did you get there? How did you organize that? How is
Well,
it organized in your country?
it's yeah, that's a good question. So it's helpful to us that there's something called the RRC, which is Residency Review Committee. And they required at some point that all emergency medicine residencies teach point of care ultrasound. So when that came out, I think, I don't remember exactly when, but around 2000, or maybe shortly after, every residency was like, okay, good, we need to focus on this, and we need to have a curriculum, and we need to have people that can teach this, et cetera. And so, but at that time, there was no formal curriculum. Um, since that time, we as societies have written up what are best practices for learning and teaching ultrasound. But at that time, we kind of made it up, and so this is what it looks like in most residencies. The thing with ultrasound is that it's a lot of hands-on. You can't just learn ultrasound from a computer. You can't learn it from books. You have to actually be doing it. And to learn that part requires somebody who's there with you actually teaching it. And so we started out with, we have a 4-year residency, and our first years now do 4 weeks of ultrasound, where their entire 4 weeks is they're there to learn ultrasound. And that's a combination of didactic sessions. So they'll sit in on fellow conference. They'll listen to lectures. They will review journals. They will review images. They'll join us for the QA, where we review the images that are done in the department. But the majority of it is scanning shifts. So they will come and they will meet with a fellow or one of us as faculty, either while we're working clinically seeing patients or not. And they'll just scan, and usually we try to make them clinically indicated questions, and say, hey, does this person's short of breath? Go figure out why. And they'll have to learn to go do a heart and lung and IVC exam. But sometimes not. Sometimes you just have an hour with a very nice person who is enjoying the scanning opportunity, and then they'll just scan head to toe as much as they can. And that's very supervised, so they can learn best practices for the scanning techniques and then interpretation of the images, et cetera. So that's 4 weeks as a first year. In second and third year, it's a little harder when they don't have a dedicated rotation. But what we try to do is meet with every resident on a periodic basis to review the scans that they've been doing clinically, and just to give them direct feedback on, this was good, this was bad, why did you do this study, how did you incorporate those findings into your practice?
Do they
If
have
you
to,
think,
excuse me, but do they
yeah,
have to build a logbook when you say you review the clinical scan they've done? Or do you just,
no,
you know,
we can just query it electronically and just figure out what scans they have. That is absolutely the way to do it. It's just extra work on the person. One could say, hey, I want you to come with me with the list of 20 scans that you've done or something, and we're going to review them. To get good at any one application requires, one, knowing how to do it, two, doing a lot of them. And you can't just see a bunch of negatives. You have to see some of them positive. We ballpark the numbers of 30 and 3, right? So for every application, DVT, for example, we want you to do 30 DVT studies, right? That's about how much it takes. But some of them have to be positive. You can't do 30 negative studies of anything, and then I know that you'll know what's a positive when you see it. And then we have them do an OSCE, right? So observed structured clinical exam, where I will come and I will meet with the trainee and I'll say, okay, do a cardiac ultrasound. And I want to see all the views, and I want you to point out what all the structures are. And then I'll show them images and I'll say, okay, what do you think of this? And say, oh, well, that looks normal. Ejection fraction looks great. Good. What about this one? Pericardial effusion, right? And you go through all the pathology so that you know that they know how to interpret, right? There are 3 things for all learning ultrasound. There's image acquisition, there's image interpretation, and then there's the incorporation of findings into practice. Image acquisition is getting the pictures, right? That you do with practice. Image interpretation you can learn from QA and from looking at textbook cases and online things. And we have a library of thousands of images. But the hardest part is really what do you do with those findings? And that you have to kind of teach in the clinical context while on shift.
yeah, exactly. And do you also have a theoretical examination, or you just have a practical one?
Um, No, there's no theoretical examination. There are some online quizzes that we have them do during their first year block. Just basic information like what's the upper limit of normal for an aorta, for example,
But
stuff
that's
like
just
that.
for practice.
Yeah, that's something that I mean, we kind of try to we are currently revamping our OSCE so that it better incorporates aspects, all of those aspects. Because the same thing, you can include questions about, okay, here's your fast exam. What would you do with this patient if they were hypotensive? Oh, I would go to the OR. Okay, good. What if you did this, right? And so building some clinical scenarios, of course, I think is important.
So when we hear about point of care ultrasound, usually people try to really make a difference between point of care ultrasound and comprehensive ultrasound that the patient would have in radiology, for example. Um, and all that difference is about the clinical context and how point of care ultrasound is performed, even though point of care ultrasound can get us a diagnostic, right? A diagnosis, sorry. Um, do you really believe in that difference between both ultrasound, or do you think by the end of 10 years, you're going to replace sonographers and radiologists for the ultrasound exam in the emergency department?
Radiologists should not worry about us. We're not planning or even wanting to or trying to replace anybody. They are really distinct exams, and there's a lot of overlap, no question. Um, you know, and just broadly, I know you know this, but just not everybody listening may, but point of care ultrasound, I'm answering a single point of care question, which I have, which is a clinical question. In comprehensive ultrasound, it's more than that. Um, when somebody has right upper quadrant pain, and my question is, do they have gallstones? I can answer that in a minute. Um, Whereas if I send them for a comprehensive one, there's a huge time delay because it will be hours before I get the reading back. And there are also a lot of other things that are that I don't particularly care about, right? So you send them for a comprehensive one, and they're looking at the kidneys, and they're looking at the pancreas, and they're looking at all the hepatic lobes. And clinically, I'm not concerned about those things. So to be able to get that answer quickly is really important. A better example would probably be cardiac ultrasound, because first of all, most radiology, when someone is hypotensive and they're dying in front of you, you need to make quick decisions that have absolute implications on life and death. And there is just no time to be able to wait for radiology or cardiology or anybody else to come over and perform an ultrasound. Same thing. I'm not so concerned about every single myocyte and how are all the valves moving. I don't have 45 minutes to wait for a comprehensive ultrasound, which is great. It will look at the entire heart. But my decision there is, how's the EF? Can I give fluids? Do I not give fluids? Is there tamponade or not? Do I need to do pericardiocentesis? Do I need to worry about intubating this patient? Should I give diuretics? And then lung ultrasound is another example of, there is no comprehensive lung ultrasound. Emergency medicine, critical care, maybe pulmonologists are the only ones who are doing pulmonary ultrasound, right? I don't know how it is elsewhere, but I can't click a button in the computer and order a thoracic ultrasound. No radiologist is doing that right now. And so there are a lot of tests that are comprehensive and complementary. So the information I get is useful to when looked at the X-ray. Um, but it is a very different entity, the comprehensive ultrasound and the point of care ultrasound.
So we both agree on that. And what we strongly believe here in Belgium is that point of care ultrasound will help you to narrow your differential diagnosis or have the right diagnosis that you want to treat immediately, choose the right treatment, but also choose the right complementary examination, which can also be an ultrasound, but performed in radiology or by any other, person that perform a comprehensive ultrasound, such as a sonographer, for example. All right. And are you satisfied with the curriculum, the point of care ultrasound curriculum in the US right now? Do you believe that when the residents are done, or the residents in emergency medicine are done with their 4 years, they are able to use correctly point of care ultrasound, or would you change something if you could change something?
That's a good question. We were just discussing this the other day. I believe that the plan as we lay it out is a good one, and that if any resident were to actually do everything that we say and everything that we require, they will 100% graduate fully competent to do point of care ultrasound in whatever applications they want. And there are a lot of applications, mind you, more every year, right? And it's entirely possible that you go through 4 years and you don't get a chance to do, a intrascaling block. And so, but you do what you can. Um, what we have trouble with is the is requiring, like, what do you do when somebody doesn't do what you ask them to do, right? At least here in the States, residency requirements, residency is a time-based thing. You do 4 years, and at the end of 4 years, you graduate. There are some places, I think in Canada, they have at least some programs. It's a competency-based thing. So you don't graduate until you've done X, Y, Z. And if you do that in 3 years, great. If it takes you 5 years, that's what it took. The American system isn't really set up like that. And what that means is that it is harder, I think, to get residents to accomplish all of the requirements because you don't have too many sticks. But when you think of carrots and sticks, right? Like, I don't have much power when a resident doesn't meet all their numbers. Like, what can I even do? So it's a little challenging. You have to kind of motivate them, and you have to get them to understand the importance and to see the importance. How do we do that? We model it, right? When I'm working clinically, I will go and I'll grab the machine, and I want them to see that I'm using it, and I want them to see how I'm using that information. And I try to insinuate, well, what would we have done had we not had that information? And I want them to see that, like, oh yeah, that it is kind of really important to do it in certain situations. So it would be great if there was some other way to kind of motivate residents. But I think the curriculum part of things, a national or some formal universally adopted OSCE would be really nice. And as you mentioned, some questions about the practical portion of it. If it would be cool if there were some online question that all residencies say, hey, we're going to adopt this, and we're going to do this, and we're going to say every resident needs to pass this before they graduate. Those kinds of improvements would be good.
Well, great. Thank you, Andrew. It's very inspiring. In Belgium, we're trying to get there. We will. It's going to be the first year that our resident will have a formal ultrasound course that is mandatory for their graduation. And they will have to take, after their 5th year, proper exam as well, practical exam, exactly as you said before.
That's
So
awesome.
you've done it 20 years ago. We're doing it now, but we hope to get to the same point in a few years. And it's partly thanks to you, because as I said, you come almost every year to help us giving the level 2 courses, and I thank you for that. So the Belgian Emergency Ultrasound Society is always happy to collaborate with you on that. And thank you for that very nice interview.
Yeah, absolutely. And for what it's worth, from what I've seen that you guys do in Belgium, you're doing an amazing job, and it's really impressive what you're able to build. And so I'm happy to be included as part of that because it's always a good time.
Thank you very much, Andrew. Great to have you in this interview.
My pleasure. Thanks for having me.